Hello, I would like, first of all, thank Professor Patrick Marcelin for the kind invitation. It's always a big honor to participate to PHC. And unfortunately, we cannot see the beauty of Paris this year, but we hope that soon we can be together again. So I'm going to talk about the management of NAFLD and NASH by the hepatologist. Those are my disclosures. Well, non-alcoholic fat liver disease can present itself in several ways. From simple steatosis, as we can see here, and with possible evolution to steatohepatitis that we call NASH. That means steatosis with lobular inflammation and ballooning. And also it can have the presence of liver fibrosis. Despite not being part of the triad of NASH, fibrosis is now considered the main prognostic factor since it can involve and correlates with the incidence of the main complications such as hepatocellular carcinoma, liver transplantation, and even mortality. Well, fortunately, most of our patients come to us with this kind of exam in the beginning of the disease when they discover that they have a NAFLD, non-alcoholic fat liver disease, to start to do a screening, to start to know what they have to do, what they have. So it's really important to start in the beginning, let's say like that. So I would propose an approach in steps, like the steps that when we walk. So I propose a 5 steps approach to manage this patient for the first time they come to the hepatologist. So the first step is to assess alcohol consumption. Most of our patients come and they say, oh, I drink just a little bit, but they are very, very, they want to express they are not addicted at all, that they don't drink a lot, but they always say, oh, well, I drink. And so the evaluation of alcohol consumption is really a challenge in the daily clinical practice. And it's not just difficult for them to estimate how they drink and how much they drink and if it's a lot or not. It's for us as hepatologists difficult too. Even in the literature, as we can see here in this slide, we have different studies with different results. In this study that was published in 2012 in Journal of Hepatology by Dunn and colleagues, they evaluated 331 patients that they consider as modest drinkers. They were drinking less than 20 grams a day, and they evaluated these patients, comparing them with lifelong non-drinkers. This group was compared with lifelong non-drinkers, and they were evaluated in both groups of having NASH. Surprisingly, modest drinkers had a lower risk of having NASH and have liver fibrosis. However, we had some limitations in this study. It was a cross-sectional study, and they did not evaluate long-term outcomes. In opposite, we have this other study that was published in 2009 with 71 NAFLD patients. They follow up these patients, so it's a long-term evaluation. And these patients had a low alcohol drink. They consider these patients that were included as a low alcohol drinkers. And so at the follow-up, 17 patients or 24% of this studied population, they fulfilled the criteria for significant fibrosis progression. So the proportion of patients reporting in this group that had progressive, reporting heavy episodic drinking at least once a month was higher also among these patients that progress liver fibrosis. Thus, in this study, moderate alcohol consumption was associated with the progression of fibrosis. So we have 2 different studies with 2 different reasons. So that's why we also have a difficulty to say to the patients what is safe and what is not safe when we talk about alcohol. Another very interesting study, it was this study of heart that they evaluated 2 prospective cohorts in Scotland to investigate the additive factor of alcohol consumption and BMI, and the increased risk of liver disease. Patients were categorized according to alcohol consumption into 0 drinkers, 1 to 14 drinkers, drinks per week, and more than 15 drinks per week. And the BMI was also categorized as a normal BMI, overweight from 25 to 30 kilos per meter, and obesity over 30. So they found that raised BMI and alcohol consumption, raised BMI and alcohol consumption, are related to liver disease with evidence of supra-additive interaction between the two, since the relative excess risk due to the interaction between BMI and alcohol consumption was observed. So frequently our patients, they are overweight or obese. So patients with NAFLD, frequently they have overweight and obesity. So that's another point when they have also a consumption of alcohol. The second step must be the investigation of comorbidities. The coexistence of NAFLD with other chronic liver diseases was frequently observed. It is highly important to diagnose additional comorbidities in the daily practice, better to define adequate interventions, and could improve the patient's outcomes. The presence or not of viral hepatitis, as I put it here, hepatitis B and C, also the use of hepatotoxic medications as steroids, amiodarone, methotrexate, among others, could potentially induce drug-induced fat liver disease or cause liver fat infiltration. We should so exclude also this kind of abuse or use of other medications. Of course, we have also make a screening of autoimmune liver disease and also other metabolic liver diseases. So we have the step 3, and it's one of the most important steps in our patients because the routine evaluation of cardiovascular disease and its risk factors is imperative in patients with NAFLD, since cardiovascular events are additional risk factor of morbidity and mortality in this group of patients. It should be remembered that there is no difference in the mortality rates associated with cardiovascular disease in individuals with NASH and NAFLD, as we are going to see in this study that was published in 2013, and they evaluated 289 patients with NAFLD, and they included the 2 major causes of death which were observed in approximately equally frequency in the cohort, were coronary artery disease here and liver-related death, as you can see here. They both comprising 25 to 30% of all deaths. So as I said, similarly, cardiac mortality was not different between patients with NAFLD and NASH. That's why we have to pay attention in all these patients at the same way. Patients with NAFLD and type 2 diabetes was also at a higher risk for overall and liver-related mortality. Another interesting study shows that blood pressure is associated with the presence and severity of non-alcoholic fat liver disease. Arterial hypertension is also associated with NASH, and in this slide we can see the frequency of NAFLD across orders systolic and diastolic blood pressure. And in this study also, they evaluated of patients with non-obese patients with BMI under 30 and patients with obesity with normal pre-hypertension or hypertension. And what they said in this evaluation, among the non-obese patients, the prevalence of non-alcoholic fat liver disease is 3 times that in the hypertensive patients compared with those with optimal blood pressure. So it's a real risk factor. So the blood pressure should be addressed by the hepatologist in the initial evaluation. So we go to the next step, and probably is one of the most important steps in this evaluation, that's lifestyle change. We have to do this evaluation, and we have to talk with our patients about that. It's possible the most important measure to be taken. As we have already mentioned here, obesity, which is extremely common in our patients with NAFLD, increases the risk of damage in the liver, hypertension, diabetes, and is one of the main global health problems. Weight loss in NAFLD is effective in improving liver disease severity. The four most common dietary patterns include the low carbohydrate diet, the low fat diet, the dietary approach to stop hypertension that they call DASH, and the Mediterranean diet. The Mediterranean diet has been recommended as the diet of choice for the treatment of NAFLD by various clinical practice guidelines, and has the great evidence to prevent and manage MET syndrome and its components, as diabetes and cardiovascular disease. Strong evidence supports the benefits of this diet in controlling body weight, fasting plasma glucose, serum triglycerides, and blood pressure. So in this study that we are seeing here of Caliora and collaborators, they studied 44 patients with NAFLD and found a significant reduction in system blood pressure and systolic blood pressure, diastolic blood pressure, and levels of glucose and HbA1c. And at the end point of the trial, all anthropometric measures were significantly better. So showing that the diet, the change in the way that people eat can really change their profile, then really change the disease, can really change what we had to do with this patient after. It's important to say that we have many diets, as I said. I just said 4 that are the most common, but we have many diets. And of course, we have in our countries to find the most appropriate, the better diets for our patients. Well, another point, key point in our lifestyle changes is the physical activity that has numerous benefits effects on metabolic syndrome. Increasingly, physical activity reduces intrahepatic triglyceride content and markers of hepatocellular injury that in the end will reduces the incidence of NASH, will reduces the incidence of fibrosis. So it's really important, independent of the weight loss. This is a randomized clinical trial that we can see the effects of moderate and vigorous intense exercise. When we compare the patients that did moderate exercise with the control patients here in blue, we can see that these patients had an important reduce when they do moderate exercise in the intrahepatic triglyceride content. The same we can see when they do vigorous to moderate exercise, when they compare these patients that are doing moderate to vigorous exercise with control patients. We do not see a difference that they reduce the intrahepatic triglyceride content in the liver, but we cannot see a difference between this intensity of the exercise. So that's, I think, a very important message. It's important to move, it's important to exercise. We don't care if it's a moderate, of course, if the patient can do more exercises, maybe it will be better in the future, but in this kind of analysis, we do not see a difference between the intrahepatic triglyceride content. So the important message, we have to encourage our patients to move, to do some kind of exercise, to move their bodies, to try to ameliorate this panel. And then we jump and we go to the next and the last step, that's use of medications. As you know, we don't have any approved medication for NASH. The EASL guideline for the management of NAFLD proposes treating patients with significant fibrosis or with less severe disease, but with risk factors as diabetes, syndrome metabolic syndrome, persistently increase the ALT, high necroinflammation, but we don't have a drug that's approved to do that. But we have in 2010 a study by Dr. Senio that's going to talk about new drugs after our presentations. And this study shows the beneficial of the use of pioglitazone and vitamin E. So they all, pioglitazone improve all histological features except for fibrosis and induced NASH resolution in 36% of patients when we compare to placebo, that was just 21%. Here we can see not only the Dr. Senio study, but also other studies using pioglitazone and placebo. Here we can see the reduction using the pioglitazone versus placebo in the NAS score. That's for a kind of evaluation. And we can see some studies that shows the benefits of vitamin E comparing to controls in survival and the compensation in patients with advanced liver fibrosis. So that are the medications that we have now. They're not perfect, they are not approved for that, but what we use in our clinical practice. Of course, we have also to discuss about fibrosis, but Professor Manuel Romero Gomes is going to do that after me. So this is the steps. I think the most important is to keep walking, do not stop, and try to encourage our patients to do the same, to have a better way, a better diet, and a better way of life, to change their lifestyle, to make them more healthy, and to have a better long life with health. Okay, so that's my presentation. Would like to thank again your attention.